Welcome to this special live presentation of the Prevention Podcast, Protecting Your Workforce's Mental Health During the Pandemic. My name is Dan Verton. I'm the Director of Content and Branding at LiveSafe, and I'll be your host and moderator for the next hour. We'll try to get to some questions at the end, so have them ready. Well before the coronavirus pandemic was even on the world's radar, the World Economic Forum was warning us of a global mental health crisis. Worldwide, 1 billion people, more than 10% of the world's population, are estimated to suffer from some form of mental or substance use disorder. And in the US, the percentage of the total population with depression continues to increase, particularly among young people ages 12 to 17. But the coronavirus pandemic and the necessity to engage in social distancing has had a dramatic impact on how our businesses conduct their daily work schedules. It's also led to extreme anxiety for many employees who may be dealing with a sense of isolation, the prospects of fewer hours on the job or job loss, family disruptions, and even illness from the virus itself. By now, I think most of us have dealt with feelings of isolation, anxiousness, and loneliness, but these emotions can be overwhelming for those who are already dealing with anxiety, depression, and other mental health challenges. Coping with this level of added stress can aggravate some of these underlying conditions. Companies that set up programs to address workforce well-being and mental health issues can help mitigate many of the negative psychosocial factors that adversely impact people and teams. And technology can play a major role in the success of these efforts. We have two great guests today to help us work through some of these issues and come up with some specific strategies to deal with the current situation. Dr. William Kassler is the Deputy Health Officer and Lead Population Health Officer for IBM Watson Health. Dr. Kassler has spent his career working at the intersection of clinical care and population health as a practicing primary care internist and epidemiologist, health services researcher, public sector administrator, and health policy expert. Also joining us is Carl J. Shapiras, the Dean of the College of Education and Human Development at Texas A&M University in San Antonio. Carl has a PhD in mental health counseling from the University of Florida College of Education. He formerly served as the CEO of the largest counseling organization in the world and is also a member of the National Academies of Sciences, Engineering, and Medicine's Global Forum on Health Professional Education. Dr. Kassler, Dean Shapiras, welcome to this special live edition of the Prevention Podcast.
Thank you.
Thank you for having us.
Paul Shapiras, I want to start with you because you've recently noticed an increase in people presenting to healthcare professionals with severe anxiety due to the current situation and the shelter-in-place orders that are in effect. What are you seeing in terms of the impact of the current levels of anxiety throughout our communities and workplaces?
Well, I think it's different depending on what community we're in, but across the board, we are looking at increased presentation of insomnia, anxiety, depression, and the American Psychiatric Association recently did a survey, and what they're finding out is basically across the board that most people are reporting some level of increased anxiety, about 50% of the respondents. And more so than that, the focus is really on the health of our family and friends. Excuse me. And so what we're looking at is how are we protecting each other and the impact that the virus is having above board on our family and friends and keeping them safe. And of course, the anxiety is also around the economy and what the long-term issues will be as we're seeing the job reports that are coming out and the number of layoffs and the level of unemployment. And even just today, the job reports that came out for the month show that the potential for this to move up to a 15 to 20% unemployment rate in the next 18 months is probably real. And so the anxiety pieces are not just mental health phenomena, they're real anxiety. They're tied to what's happening in the population and what's happening in the world. And as a result, we have to be temper our review of that to some degree and try to differentiate it between what is a clinical anxiety level or a clinical depression level and what is a natural response for people.
Yeah, so I think that's a really good point because I think the setup to this may have led folks to potentially believe that we were discussing only the clinical statistics. You know, the 1 billion people who had already been diagnosed with some form of mental health issues. But what we're really talking about here is new cases of anxiety and potential depression. Correct?
Correct. And so we're seeing, what I'm seeing anecdotally, we don't have a lot of hard data yet because this is so new. But what I'm seeing anecdotally in talking with physicians in the community, GPs especially, are people trying to make appointments and reporting in with experiencing some of those anxiety symptoms like feeling tightness in the chest, which is a symptom of COVID. And they're also experiencing that sense of overwhelming fear, and they're having some trouble focusing, and they're coming into the GP and because they're worried about either having the virus or they're not sure what is going on with them, and it's ending up being just a anxiety presentation as a result of what's happening in the community.
Dr. Kassler, as I mentioned in the introduction, experts like yourself have been warning the world for a while now that we are in the middle of a global mental health crisis, well before the coronavirus pandemic dramatically altered our lives. So we're now weeks into social distancing and remote working for those of us fortunate enough to be able to do that. But if you believe Bill Gates, who I think knows more about the data behind global pandemics than a lot of people, if we want to avoid doing this all over again, this shutdown in the fall, we're looking at another 6 to 10 weeks potentially of significant social distancing. And you pointed out last week that in a new Axios Ipsos poll surveying about 1,000 people, 43% of respondents said their emotional well-being has gotten worse in the past week as more people deal with this sense of isolation. So just how serious is the situation from a mental health perspective, especially for people who may already be dealing with underlying mental health conditions?
Thank you. I would like to echo what you said in your introduction and what the Dean just said. I tend to think about these things in two buckets, if you will. People who don't normally tend to have anxiety or depression or mental illness, and those who have a diagnosis. So let's get personal. Let's take me, for example. I'm fortunate enough not to have a mental illness or anxiety. I'm trained as a physician and as an infectious disease epidemiologist. I have a good job. And yet when I look at the news and I see the pictures and I go to the grocery store and I see the empty shelves, it's really, really hard for me, knowing what I know, not to get anxious. And so then think about folks who tend to have those challenges to begin with before the pandemic. It's really, really hard for people with severe and persistent mental illness to get treatment. In fact, there are 1 in 5 American adults that have a serious mental illness. That's about 44 million people. In the last year, 60% of them couldn't get treatment for their illness based on stigma and access to providers. So as we think about the current extraordinary circumstances, they're profoundly challenged to get treatment, and they're much more stressed.
Carl Shapiris, what about the healthcare workers right now? We have a lot of healthcare professionals, higher education professionals from research universities tuning in today. These medical professionals are being asked to compartmentalize so much for so long. For many of them, this goes way beyond anxiety, right? They're downright scared to go into work. We see it every day on the news. So, what specific considerations or approaches to mental health protection should we be thinking about for our healthcare industry?
Well, this is so hard. First, before I even respond to that, I just want to acknowledge the bravery of the healthcare professionals that are out there in the trenches doing this work, knowing that the exposure is real and seeing colleagues become infected and struggling with their family members and friends being also potentially infected. It's very different when a healthcare professional does something like Doctors Without Borders and goes overseas and puts themselves in a hot zone and does that on their own. But in this scenario, we're looking at having to face the virus in conjunction with their peers, while at the same time their families are right there in the community with them, and their families are impacted by this. And I heard a story this morning about a healthcare worker who was concerned that he brought home the virus to his sister, who is now intubated. And as a result, this is a real level of anxiety that is just permeating throughout healthcare. We're hearing stories about, on one side, healthcare heroes who are going out into the community and finding ways to continue to deliver services. And we're also seeing examples of fear-based actions in some instances. And I think that it's important to acknowledge those. We don't have real data yet for the US on what the impact is for healthcare workers. So there was recently a study in China on healthcare workers, and what they saw in especially Wuhan and other hotspot areas was the same things we're seeing in the general population. A lot of general distress, a lot of depression, anxiety, insomnia. And so, the stories are just sweeping in now from New York, and we're seeing what that looks like on a day-to-day basis. And there's not really a way for these folks to get relief. They're working endlessly. And then they're, at the same time, like I said, worrying about their families at home. And what Dr. Kessler said, I think is important to highlight here, that we have a critical shortage of mental health care in the country. When you look at the county by county maps, almost every county in the US is a critical health care shortage for mental health. And so there's not enough providers to be able to address these issues for our healthcare workers and for our general population. And so their focus right now is really on how do they continue to provide their services, yet at the same time, we have to find some relief for them from a mental health perspective. So there's not a clear answer to this yet in terms of providing the services for our healthcare professionals. One of the ways we have to look at it, I think, is through some of the telemental health opportunities that are currently available. I think that is becoming especially more prominent now, but there's a lot of state regulations that impact how those are provided. And so in states where there are critical shortages of mental health, there still may not be enough telemental health providers in those states as well.
When it comes to work, many companies, including Dr. Kessler, IBM, are prioritizing an inclusive culture and workplace because mental health is an often ignored aspect of inclusivity. In fact, a new report from the IBM Institute for Business Value, How Technology and Data Can Improve Access to Mental Health Resources, names the work environment as one of the most significant factors that can affect an employee's mental health. And interesting enough, one that employers obviously can influence. So companies that set up programs to address workforce well-being and mental health issues can help mitigate those negative psychosocial factors that we've been talking about that adversely affect people and teams. Dr. Cashley, you argue that there are three focus areas for our mental health that employers and the workforce should prioritize right now. Can you walk us through those three priorities?
I'm happy to walk you through those three priorities, but first, if I might just kind of frame them a little bit. So I think companies really recognize, and I'm proud that IBM addressed mental health long before the pandemic and is rising to the occasion during the response. But companies are recognizing that if they're going to care for their employees, they really have to address mental health. It's as important as physical health, and the brain is certainly part of the body. There are several domains in which employers actually can make a difference, both as a purchaser of health care for their employees, so they can make sure that the plans that they purchase and offer for their employees are robust when it comes to a wide range of mental health services. The policies and practices that they have in the workplace can make a big deal. They can really impact whether it is a healthy workforce or whether it is a toxic workplace. The culture, treating people with respect and dignity, and making sure that there is a culture that does not stigmatize those with mental illness. Then offering specific programs like the Employee Assistance Program, resiliency apps, and we can talk more about that when we talk about the technology. These are all really, really important. But if we turn now from, I would say, the corporate response to how I tend to think about stress and stress relief in this time of, in these scary times of pandemic, I tend to think about this in terms of fear, resiliency, and self-care. Fear is natural. Fear is an evolutionary signal that tells us, hey, there's danger out there, pay attention. And so once, our animal brain basically says, okay, you've got fear, fight or flight, let's run away or let's go at it. Our human cognitive brain comes up with a plan. How do we address this danger, this fear that we perceive? Once we've developed that plan, though, ongoing fear adds to psychosocial stress. It decreases our performance, and it truly can be corrosive. So we have to understand that once we develop that plan and act on that plan, we can let go of some of our fear. The second domain that I tend to think about this thing is resiliency. Resiliency is our ability or lack of ability to bounce back after a trauma, after a hardship, to adapt to the challenges. And resiliency is something that is not innate, and it can be strengthened. We can strengthen our resiliency through a number of very common sense types of activities like exercise, like stress reduction programs, like turning to our faith and our cultural traditions, and learning how to reframe events in the positive. So rather than complaining about social isolation and social distancing, appreciating that we may be stuck with our kids and have more family time, or are better able to read a book, or trying to look at doing things over the web. And lastly is self-care. It's really important during these challenging times to take care of ourselves. It's like that airplane announcement that the flight attendants had when the oxygen mask comes down, put yours on first before helping your child. And so it's important for both companies and for individuals to emphasize self-care, getting sleep, eating well, participating in hobbies and activities that you like to maintain some normalcy, looking at stress management and relaxation techniques, getting connected through the internet, and making every day meaningful and purposeful.
Now, acknowledging and acting on mental distress in these uncertain times is key, obviously, to lessening the impact. And this is where, Dr. Cashley, you say technology can help. Tell us what IBM is learning by working with your employees, your clients, and academic partners about how technology can strengthen our communities and our workforce during these types of crises?
Thank you. So IBM, in addition to being a large employer, 380,000 employees across the globe, we're a tech company, and we work in health technology as well. And so as we think about this, the dean, yourself, you've talked about the challenge to access. Technology can improve access. Remote or virtual visits can really help folks who can't go out because of distancing, who have transportation challenges, who live in rural areas where there are no providers. Trust is also something. It turns out that the anonymity afforded by computers and by those remote interactions allows individuals sometimes to be much more candid and self-revealing to a computer than they might be to a person in front of them judging. Then we have this whole new idea of health apps that are on our phones and our mobile devices. We've observed that it's kind of like a wild, wild west out there with the good, the bad, and the ugly. So one of the lessons learned is that we collectively, the subject matter experts, clinicians, and other professionals, need to curate the available apps out there and recommend those that have evidence-based, that work, that have good user experiences, and offer them to our employees and recommend them to our patients. Lastly, AI, as it's impacting all of society, has a real potential to add to our ability to treat mental health. I'll point to a couple of different examples of that. First are chatbots, these automatic conversational algorithms that can actually help individuals remotely. And while those technologies aren't a substitute for a real live therapist at the other end, they're getting close to being able to have a role. So pay attention for that. But in what's happening now and in commercial products are use of conversational analytics to allow the therapist to get more insight. So I'll mention one program that works at workplace resilience, but also with veterans that have post-traumatic stress disorder, and that's called Teatros. This is an online counseling program where a real therapist leads anonymous group sessions, and in addition to the standard evaluations, they have AI observing their interaction and looking at the sentiment and the personality and other characteristics and feeding that information back so the counselor can deliver much more personalized messages. The second example is called Grit, and that too is for veterans who have post-traumatic stress. And that's an app that allows an individual to bring to develop a squad, to bring their military buddies into a social media situation where they can then exchange very confidentially peer support. It brokers interactions with the job market so that the AI can assess what that individual's unique skills are and then go out and find jobs through job brokers like Burning Glass. And then it offers a mind gym. It offers mental health exercises that we talked about to build resiliency and self-care based upon a personalized assessment. So those are two examples of where commercial products are using AI that are actually in the marketplace.
Yeah, those are really great examples. We're doing a lot of work at LiveSafe on the AI aspects of guiding users through reporting safety and security concerns and then providing organizations with that new level of insight and analysis that you really can't get anywhere else. So I think that's definitely the mental health side of it is definitely an area to be looked at. Carl Shapiris, are there technology-based approaches or strategies that you think can make a difference in the current national emergency in terms of keeping people connected and giving our workforce a greater sense of certainty and well-being?
I think that's a great question. What Dr. Kastner was talking about is critical, that we have the technologies that are being developed through IBM and through other industries. I want to talk about it from a more basic standpoint, because what we're seeing where I live in San Antonio is a real digital divide, where we have some economic differences in our community. And so on the north side of San Antonio, the average income level is around $90,000 for a family of four. And on the south side of San Antonio, we see about a $25,000 to $30,000 average income for a family of four. And a lot of those families don't have access to internet. Many of them don't have computers. And so for us as a university, as we're looking at we've moved to remote coursework for our students, one of the things we had to figure out first is, do our students even have access to internet? And so there's a critical issue here in terms of this, because providing that internet access is not very easy. So we attempted to purchase hotspots for our students, and those, of course, are on a production back order because of the huge demand right now. And so finding alternative ways to make sure they get access is one of those struggles we're still looking at. It's the same for our faculty. Some of our faculty live in remote areas where they don't have digital access really easily. And so we had to do some searches to find hotspots for them as well. And it's a connection issue is the first part of all this, making sure that our employees who are working remotely, who have never done so before, end up having the access they need, and that's a struggle. I think there's two pieces in this puzzle as well, when we're looking at the sense of community for our employees. For a lot of companies, remote work has been a pretty common activity. And so for individuals who have worked remotely, it's not as heavy a lift in terms of figuring out how to make their connections. They probably are using a lot of different software systems, and they have their routines built in. Yet we still have to recognize that their remote work is heavily impacted, because they now have everybody else home with them at the same time. And so if they do have pretty good internet access and they're trying to get into a Zoom meeting or some type of a Skype or WebEx, that's a big impact on the bandwidth for the internet for the household, and there may be multiple people in that household trying to access it at the same time. So it does make some challenges for those individuals who already work remotely. We see those instances that we would laugh at, where kids would come into the room while somebody was doing a Zoom meeting or something along those lines. That's becoming pretty common. We're seeing that. I'm seeing that every day during Zoom meetings right now. The second bucket is those folks who did not work remotely previously. And so there's a big lift there in trying to create that sense of connection and that sense of community. In some cases, it's a learning curve for them to figure out how to use particular software systems that they may not have needed before, and for them to think about how to build that sense of community while they're at the same time they're trying to figure out how to do their job remotely. So they're getting a lot of mandates from leadership about how to increase or maintain productivity while they're in a remote location. And in a lot of cases, they're not getting that sense of grace that folks need during this pandemic to get the kind of messaging that helps them to build that community that will help them be productive. And so what we're doing here, what I'm doing with all of my employees, is I introduced them to Microsoft Teams. We weren't using it before. So we started to build that out for each of the groups, and then built in Yammer as a platform so they could create that work social media connection. But I had to do voiceover recording videos to show them how to use some of these platforms they haven't used before, and then walk them through and help them to understand why it's important. So putting in kind of a change management process that really helps your employees to buy into why this community component is so important for mental health and for productivity. And so what I'm seeing is a lot of companies are rolling out products and support services and things like that without implementing that change management process that helps the employees understand why it's important. And part of that is really modeling and demonstrating. So I'm in there every day on these teams, and I'm making connections for people when I'm prompting them to get involved, and I'm helping them to recognize why it's important to also post positive things. Because what we're getting constantly in our social media platforms is the updates on the virus, how many people are dying, how many people are infected. And what we also need is that sense of just humor and connection. So what I've told my faculty members here is find some time for a virtual happy hour with each other after work. Make time for that kind of a connection. Make sure that you're giving grace to each other to recognize that the person on the other end of a Zoom call might also be trying to homeschool their children now because schools are closed, and they also have their spouse at home, and they've got to take care of all of the responsibilities of the household that they may not have been doing previously. So it's a big lift. And so we have to, as employers, really provide that sense of support for folks as they're trying to do this remotely, model what good behavior is in terms of connectivity, and then give some level of grace as people walk through it. Help people understand that they're human, that there's a learning curve, and that there's a chance here for us to look at how we're operating differently and still be successful in it.
You know, those are really great points, Carl. In fact, I'll share with you, last week we did at LiveSafe, we have, a company over 50 employees. We did a virtual happy hour, as you mentioned, and we played a virtual game of bingo, and everyone had their drink of choice, and we could see folks and interact and just joke around with each other. And I can't tell you what a morale booster that was for the company. And we plan to do it again throughout this crisis. So I think something so simple like that, granted, you really do, we're fortunate here in Northern Virginia where we have the connectivity to do that. But that is something very easy to do if you can do it.
Yeah, so true. And it goes so far. And it's the same thing of helping your employees to understand how to do that with their families too. Celebrating birthdays. I've seen so many people post on Facebook about the loss of a birthday party for a child and what impact that has. You can celebrate it virtually. You just have to think about how to do it differently, and celebrating milestones with your employees in the same way.
Right.
So I just learned about something called the Birthday Caravan. Have either of you two heard of that?
Have not.
I have not.
This is my son, my college senior son, who's now home and doing work remotely. Everybody who would go to the birthday party gets into their cars and they drive by the house or the apartment of the birthday boy or girl. They'll slow down, they'll wave, they'll honk their horn, they'll have balloons, and it's kind of a little bit of a drive-by, socially distant celebration.
That's great. Improvise and overcome, right?
Mm-hmm.
Necessity is the mother of invention, and we are social creatures, and just because we have physical distancing doesn't mean we need to have social distancing.
So true.
I think from a technology side, there's a real positive to the way this is unfolding, in that where people may not have known how to make these connections if they weren't familiar with platforms before, they're learning. We're seeing people of all ages learning how to do this right now. And it's changing the way our society will operate once this pandemic is over. And so I think that there is a positive side to the technology component and how that's going to unfold for our future.
But your cautionary tale of the digital divide, absolutely relevant here. We need to be figuring out a way to make sure that everybody benefits. Going back to mental health, those with serious and persistent mental illnesses tend to be economically challenged as well. They tend to be vulnerable. They tend often not to have the benefits of the economic and social benefits of society that many others do. So we've got to figure that out, and we're not there yet.
No, you're so right. All of my clinical work has been in low-income areas and working in community mental health. And most of the patients that I'd have come in were far below the poverty line, and in some cases they would do things like search for cans and bottles and turn them in for some money to pay for sessions. So they don't have internet access. And finding ways that through mobile units, through telemental health units, to provide services to those individuals is something that we have to put a very clear focus on right now.
And what I'm being encouraged by is I also practice at a community health center, a safety net provider for the uninsured and underinsured. Is we are increasingly seeing penetration of cell phones that have internet access, of smartphones. And so while there may be less broadband connectivity in people's homes, more and more I'm seeing access to mobile devices. And so I'm really encouraged by the opportunity if we can curate a set of apps that are effective and safe and affordable, that there may be that opportunity to get some of these technologies out.
I agree with you totally on that, Dr. Kessler, and I see the same thing, that while people do not have internet access in their home, regardless of level of poverty, most families do have a cell phone, or individuals have cell phones of some nature. And the challenge, I think, still is the free apps and making sure that the underinsured and the impoverished have access to free apps that drive those mental health services for them.
Indeed.
Thank you for that. Before we get to questions, just remind everybody, we do have a couple of questions already, but please, if you do have questions for either of our guests, go ahead and submit them now through the control panel. Before we do that, I want to, I talked a little bit about what we had done in the past week or so at LiveSafe. I want to briefly describe what we're doing from the perspective of our corporate social responsibility program. And I want to also describe a free capability that we're making available to any U.S.-based business or educational institution. In essence, any organization represented on today's webinar is eligible if you're based in the United States. So we're offering a free limited version of the LiveSafe platform to any, as I said, U.S.-based organization that needs an effective means of communicating relevant information to their communities during the current national emergency. Now, the platform will enable members of your workforce or your student body to engage in two-way communications with your COVID-19 coordination or response teams, access critical resources and guidance, and of course, it'll give your teams the ability to leverage geo-targeted broadcast messaging to get information out to your communities. There's been a lot of talk in the last week or so. Many of you might have heard the new app released by Apple, but we want to make it clear that the Apple release is really just a minor step in the right direction right now. We've been at this for 8 years, and what we are offering is a robust platform for two-way safety and security communications, anonymous reporting, which can be especially important in cases dealing with mental health distress, live resources directly from the CDC, access to emergency services based on your actual geographic location, and the ability for your organization to broadcast, again, that critical information out to your workforce or your student body. And of course, those broadcasts can be based on groups or geographic location. And also, you'll notice one other capability on the very first card on the app here shown on your screen. You even have direct access through the LiveSafe platform to the Apple COVID-19 screening tool, if that's what your concern is. This is a free offering, but it's really the most robust community engagement platform for safety, security, and now mental health available on the market today. This is all we do at LiveSafe. So we're not just trying to repurpose a generic safety app. We engineered this platform for ease of integration and flexibility to respond to these types of emerging threat scenarios. And it's free for the remainder of the year. So information on how you can get this free offering is at our website listed here on the slide. And of course, you can download a 2-page overview from the dashboard. So I urge everybody to check that out. We're trying to do our part to help our communities and our country get through this. And I think we have a particularly special role to play given what we've been able to develop. So with that, I'd like to open it up for some questions. For both of our guests, this is for either one of you. Is there historical data on increased issues associated with mental health, for example, substance abuse or suicide, from previous national trauma events such as 9/11 or the Spanish influenza? I'll open it. Either one of you would like to chime in on that one.
Dr. Kastler, would you like to take it first?
Sure. I am not familiar with those statistics. I do recall that when I was in training as a junior epidemiologist in San Francisco during the earthquake, what we found by looking at emergency room data is that for the first few days, everybody stayed away. That was very activating, that people rallied to just get through their daily lives. But then there was a spike afterwards as people kind of exhausted. And then there was, it appeared to be an exacerbation, increased visits, increased folks who were newly diagnosed with anxiety and more severity for people that already had it. But in terms of the historical data from previous pandemics or from 9/11, I'm not familiar with that.
Okay. I have looked at some of that data, and there are a number of studies that have been done post national emergencies and pandemics, as well as 9/11, and then natural disasters too, when we look at those. And what we see across the board in those cases is one of the big things that I don't hear a lot in the news is an increase in domestic violence cases. And that's a critically important issue for us to pay attention to. And we see that pretty consistently across the board when you change to some isolation of couples and families. Putting more people who are prone to domestic violence in an isolated spot with their partners is going to just naturally lead to increases in incidents of domestic violence. And so we do see that happen more regularly, and we're already seeing it happen now with the COVID-19 response set. Substance abuse patterns do increase dramatically as well. And so that typically is what people's, when we see people who have addiction issues, that often is a coping response pattern for them to numb feelings and to self-medicate through whatever their addiction is. And as a result, we see spikes in those kind of issues when we have these kind of pandemics and natural disaster elements. The other thing that we see is increases in PTSD and people having trauma response sets. And that's also the case for healthcare workers. That I've actually done some of the work with healthcare professionals after natural disaster events, and we see the piece of compassion fatigue that increases pretty dramatically, and incidents of post-traumatic stress disorder. And so there has to be some post-pandemic intervention strategies that we put into place that support the healthcare workers after we go through this process, because they're certainly being impacted right now. In addition to the substance abuse and domestic violence issues that we see increase pretty dramatically, we also see a lot of issues with lingering anxiety. So while the anxiety is fairly normal right now in the midst of the pandemic, once it ends, that anxiety tends to hang on for some people. So where they may not have had it before, they continue to present. So it's triggered something that was within them during the process, and so they may need some help and extra support in order to manage that after the pandemic's over.
Very important point on both of those issues, domestic violence and substance abuse. We're actually doing some work now trying to remind folks about domestic violence issues and how it often spills over into the workplace. And like you said, when this is all over, a lot of these issues will be in a heightened state and they will continue for some time. So we need to start planning now for dealing with those issues as an enterprise. Another question that we have is, how can you stoke excitement around things like a virtual happy hour? I feel like a lot of my team spend all day on their computers. I'm not sure if they'd want to spend any more time online.
Well, I'll take a crack at that. I think these are unusual times, and people have a need to be connected. And I think the questioner would be potentially very surprised. The dean mentioned some of the work that he's done in his department, and I have found that as well with my teams, that we want to connect. We want to know how our colleagues are doing. We want to know how our family is doing. And so people don't perceive that as an extra burden. So we've done exercise challenges. We've had, I do office hours, where twice a week, recognizing that people are stressed and anxious, I will do virtual office hours where folks will come in on a webinar and ask questions. And then, of course, if they want more personal guidance, we do that privately. But within 2 minutes after I announced it, folks were, yes, let's do this. And so I do think during these exceptional times, people want to connect.
I so much agree with you, Dr. Kessler. I think it's the messaging that we send out about why we're putting together a virtual happy hour, and making sure that you're letting people know that this is not a work event, that this is really a way to build community and to connect and to not feel isolated, that we're going to get together and we're just going to enjoy each other's company. And while you're at home and you're stuck there, this is another way for you to just feel connected to the world.
And if I could add to that, again, getting back to the theme of what employers can do to create a culture, I just loved your phrase, a sense of grace. But when people care about you, when managers do these things genuinely, show care, that makes a difference in the culture in an organization. It makes people feel empowered. It makes people feel valued. And that just feeds this sense of connection. So I would urge the questioner not to come into this with with pre-existing biases, but to be open to some pandemic magic happening within the team.
Here's another question. Aside from LiveSafe, what sources are the most reliable regarding COVID-19 stats and information? This is a really important question because people are overwhelmed with reporting on this, and it's all pretty much doom and gloom. So what sources should they put their trust in, and what sources should generally people try to avoid?
So I'll start. As a physician, I look to trusted evidence-based medicine. So I look to the clinical journals, and I will look to the CDC, the World Health Organization, to state health departments, and to respected academic organizations. So Johns Hopkins, for example, does a really great epidemiologic tracker, and they scrape data from reliable sources and present that. I think for the public, it is very important to go as well to your physician, and to your local health authority, because this is a very locally, the response is local. And so you can read what's happening in China, what's happening in Korea, what's happening at the CDC nationally, but each community has different resources, have different challenges. And so the local health department is going to be the most reliable about where you can go to get tested, what do you need to do, what are the distancing measures that are required or suggested. So to sum up, the Centers for Disease Control has public information as well as information to providers, trusted academic universities, your physician, and your local health department.
Yeah, thank you for saying that, Dr. Kessler. The local piece is really critical with the local health departments because the virus is so different from community to community right now. One of the things I've found I've had to do, and this is even with large groups of PhDs. So I spend time at a national level with groups of faculty members online. And as a researcher and a statistician, which is my background in addition to mental health, I have taken a lot of the models that have been put out, for example, the University of Washington model or the Imperial College model, and taken the time to break those down for people so they understand what the statistics mean. Because what we're seeing come out are pieces of the models in the news or on Facebook or in other elements, or not a total reporting. And so what I try to do is to help folks really understand what the data means and what to plan for. So for example, we've been seeing a lot of discussion of at first that this would be a few weeks, then it'll be a few months, then it'll be, and so I try to really break down what those models are and what the implications are for flattening the curve and how that changes the data. And as a result, I think that those folks that I'm teaching the models to can then teach others, and help to share the information. But what I always suggest is go directly to the source, like Dr. Kessler was saying. Go right to the CDC, go to the World Health Organization, go to the local health departments. Don't even take my word for it when I'm explaining it. I provide the links to the reports, or I provide the copies of the reports, and all I do is try to break it down for people. But go right to the sources and make sure you understand what those models are.
And if I could answer the second part of the question, and I agree, Dean Shapiras, who not to go to, where not to go. We have seen an outbreak of armchair epidemiologists. We have seen people who are data scientists but don't have the subject matter expertise around epidemiology and clinical and public health offer quantitative models that just aren't based in reality. And we've seen celebrities, actors, sports stars, and personalities come out with actually very dangerous advice. And so I would look to anybody's credentials first before believing them. Are they a clinical doctor? Do they have an epidemiologic background? Are they from public health? Do they have the subject matter expertise to speak critically? Because so many people are using this as an opportunity to self-promote and to make noise, and they shouldn't be listened to.
Dr. William Kassler is the Deputy Health Officer and Lead Population Health Officer for IBM Watson Health. And Carl Shapiris is the Dean of the College of Education and Human Development at Texas A&M University in San Antonio. Dr. Kassler, Dean Shapiris, thank you both for joining us on this special edition of the Prevention Podcast.
Thank you for having us.
Thank you.